Okay, so I'm really keen to share this material with you. I'm going to assume that some of you may have read the article, some of you may not have. Hopefully you, I think, saw it ahead of time. It was shared with you, so you know that this is the cover page of the article. So just recently published in BMJ Open. And obviously this is going to be the focus of my presentation. Want to just make a couple of comments in terms of background for the study, the Canadian Patient Partner Study, and then introduce a few members of the team, some of whom are actually here in the meeting, and then others who are not. So briefly, the Canadian Patient Partner Study is a CIHR funded research grant. This grant was funded in 2019, fall of 2019, and the research aim is a fairly simple one, is to gain a really good understanding of the patient partner advisor community, right, across Canada as an emerging resource. So the idea that we have so many more and more patient partners, advisors, people in a variety of roles, right, in health system organizations, governments, research, et cetera. And really, my sense when we wrote the grant was that we didn't really have a very solid understanding or comprehensive understanding of who these individuals were, what they were doing, their activities, their motivations, experience, et cetera. And then how do we think about supporting this really growing resource to the Canadian health system? And I think it's that kind of almost human resource way of thinking of patient partners that perhaps was what caught the interest of the review panel. I don't know, but they liked it enough to fund it, so we're happy about that. So our specific objectives were to really do this describing, mapping, and exploring, right? Really dig into as deeply as we can to really understand this community, this population of patient partners and advisors across the country. And I use both terms partners and advisors because depending on where you are, depending on which province, which locality, the different terms are used and different labels. And in fact, that's been part of our early part of this project too, is to really just understand all of the different labels and names and nomenclature that's used in this growing field. We're also interested in assessing really the prospects for this role, right, to contribute. So how does the role contribute? How might it contribute even more? And what are the challenges that individuals in this role face, and how might these be addressed? So a number of things we're trying to do with this study. Our team, which is shown here in terms of the investigator team, so just clockwise from 1 o'clock on my screen, Carolyn Canfield and Marianne Levasseur are our patient partners from the Patient Advisors Network, who've been really contributing in fundamental ways to not only to, you know, as the work has continued, but actually from the very beginning in terms of conceptualizing the research study in and of itself. Jeff Wilson from Nova Scotia has been incredibly helpful in that pragmatic kind of engagement practitioner role that he plays with Nova Scotia Health Authority. Paula Rowland, who has a background in sociology of expertise in health professions, has brought some really good theoretical thinking to our project, is based at University Health Network in Toronto, and faculty member at University of Toronto. And at the University of Calgary, so in Alberta, where most of you are, some of you anyway, Miles Leslie, who some of you may know, and Pierre-Gilles Desforest, who used to be at the University of Calgary, has since moved on back to Quebec, also a member of the team, at least at the starting stages of this project. And then last but not least, of course, my co-principal investigator, Meredith Van Stone, who works with me here at McMaster in the Department of Family Medicine. And the individuals who are not shown here, but are actually in the Zoom meeting today, are Laura Tripp, research coordinator, who's been working with me for a number of years, Julia Rogers, who just recently joined our team, and Roma Damanaskar, a doctoral student of mine. And those were the only ones that I caught in the Zoom. So I'm hoping I didn't miss anyone on my end. So I just thought I'd give you a sense of who we are. So very much a pan-Canadian group and very interdisciplinary. And I think that has been what has really added value, tremendous value to this project, is to have people looking at this question, looking at our research aims and our objectives from very, very different perspectives, disciplinary backgrounds, and roles, right, in the health system and in health research. So just to give you a sense of where we are in the project, so we're really well into the first and second phases. I won't say phase 2 is complete because that's our survey phase. While the survey itself has closed, we're doing a lot of additional work. So this paper that I'm presenting today is really just one of a number of outputs that we expect to have from the survey. It's an incredibly rich data set, and we really expect to be doing a lot with it. And I'll talk about phase 3 towards the end of my remarks. And I'm going to also just very quickly say that Sandra Holdsworth was introduced by Sadi at the beginning, and Sandra, as she was introduced as a member of the PAN board, is actually going to make some comments at the end of my remarks from a patient partner's perspective. So you'll hear from her shortly. And so just sort of a few key design details. And again, maybe for those of you who haven't had enough time to look at the paper or haven't looked at it in a while, this was an online cross-sectional survey of self-identified patient partners. And I think that's really important, this idea of them being self-identified. We had a lot of design discussions about whether to go that route or a different pathway in terms of organizations identifying their patient partners. And we wanted to really have these individuals who responded to our survey self-identified. The structure and content of the survey was informed by previous surveys, whatever we could find in the field, not a whole lot, I should say, but I think there's someone in this meeting, Tara McCarran, who's responsible, at least one of the other contributions to the field, if I've got that right, an Alberta-based patient partner survey. As well as our team members, right? A mix of researchers, patient partners, engagement leads who actually really contributed in significant ways to designing the survey. And importantly, co-designed with members of our of PAN, right? Of the Patient Advisors Network. And I would say that happened, again, in very foundational ways from the very beginning of the conceptualizing of the survey. What do we want to, analyze here? What are we looking at, to everything from even the look and feel of the survey and a lot of involvement in the piloting of it before we released it. The survey includes a mix of closed and open-ended questions. Importantly, to have those open-ended text box opportunities for patient partners to weigh in, going beyond the kind of the Likert scale, the closed-ended, to say what's really going on behind the answers to those questions. So that was a really important decision, and I think has yielded some of that very rich data that I've spoken about. Wanted to make the survey very accessible, written at a grade 9 reading level, minimal jargon, and included in fielded in English and French, so we could take advantage of the significant patient partner community in Quebec and outside of Quebec who are French speaking. And so here's the important piece analytically. What were our analytical domains, or kind of the variables we were looking at building into the survey? So we're interested in looking at patient partners demographically. So who are, Canada's patient partners? Functionally, how do they enter their roles? What are the activities they get involved in, with what time commitments and longevity? Philosophically, what motivates them to do what they do? Why have they been chosen to do what they do? Professionally, what are their skills that they bring into their roles? It's not just about them building skills, but they bring tremendous skills and expertise into their roles. And then what do they also feel they need, right, to enhance those skills? And what are their perceived impacts, right? How do they feel they're actually contributing through their partner work? What are their views on the level to which they feel valued? A member of teams, and then ethically, and this was a really important contribution, I think, to the survey design, is to ask those really hard questions about challenges and stressors that they face and experience in their roles. And so the survey was completed between October and December 2020. Respondents recruited, as I said, through patient partner networks and health system organizations, but not in a sense of, can you give us your list of, and we'll contact that way to say, could you please share this survey link and let people know about this survey, so that, again, patient partners could self-identify, and that gave us a chance to really understand from their perspective how they self-identify as patient partners. So challenge with this methodologically is there is no database, right? We have no denominator of X number of patient partners that we were looking to sample. We were snowball sampling essentially through email and social media. And so, some of course challenges around this. We obtained 603 survey responses. So again, have no idea what that is as a numerator, because we do not know what the denominator is. So have no sense of a response rate, so to speak, which is what we usually think about, right, when we're doing this kind of survey work. This was we didn't think it was necessarily going to be a very time-consuming survey to complete, but in fact, people spent an enormous amount of time. 37 minutes medium time to complete is a significant amount of time that people were spending on this. And I think Sandra is going to speak to this in her comments. And as I mentioned, the open-ended responses generating over 500 pages of open text data, so a very rich data set. So I want to, instead of really sharing results with you, because for those of you who've read the paper or at least glance at it, there are a lot of tables, there's a lot of data, and there's far too much to present in the time I have. And I know this is a journal club, so I want to present in the spirit of a true journal club and give enough time for discussion. But I want to highlight 3 key messages or themes and allow us to maybe jump from that starting point. So the first one, this key message that patient partners are a homogeneous group sociodemographically, and again, thinking about our analytical categories, right? So a predominantly white, female, over 50, retired group with relatively high socioeconomic status. Now, I think perhaps to many of you, that's not a huge surprise. I think, to be honest, that was one of the things that motivated us to write the research proposal for this study, because we heard a lot of that anecdotally. People would talk about this. And I said, we need to empirically look at this and examine it. And so that is borne out in our results. However, we have to keep in mind that this was our survey, our sample, right, of the 600 patient partners. That doesn't necessarily assure us that that is true, but for this sample, this is what we found. So I think a few things that I would say about this key message is that certainly the population that fits this, these sociodemographic characteristics certainly reflect important characteristics of current health system users, right? So if we're thinking of the extent to which this group represents or reflects who are our health system users, I think there's good representation here, a good reflection of, and caregivers as well, who predominantly we know are women. But I think, we can all agree that there are some characteristics that certainly are not reflected or represented well, right, within our sample of survey respondents, and those characteristics being around race, education, and income. And so I think that reflects the current critiques, right, of the lack of diversity of patient partners and the underrepresentation, right, of certain groups of equity deserving populations. And this was an interesting theme that was just kind of popping up. It's not as if this is new. There have been many critiques, certainly in this area, but certainly around the time that our survey was actually being administered, if you can think about 2020, fall of 2020, this was a very, very animated discussion around this. And so it's interesting that we're in a position to show with our data how we, essentially our results confirm many of the critiques that are kind of in the popular discourse around patient engagement in health systems. So I think more work needed to understand really, how we address this issue and to some extent how well we can do this or whether we can do this. I think I want to urge us to kind of reflect on how it's not easy to just simply sort this out as a recruitment issue or a recruitment problem, and when we just recruit people better, we'll actually find our way out of this. I'm not sure it's as simple as that, but perhaps we can chat about that in the discussion. And this is just the data slide to support the key message. We don't need to talk about this in detail. Again, this is basically pulling the relevant data out of the paper, but I have a data slide for each of the key messages. So the second key message or discussion theme, right? So on the one hand, we talk about our patient partners being homogeneous sociodemographically. They're also a highly heterogeneous group functionally, right? And I think this is what kind of allows us to push further, right, in really understanding this population or survey sample. So over half of our respondents describe themselves as partnering episodically with just one or two organizations. And yet there's a very small group, but a sizable group of heavily engaged, what we kind of fondly talk about, our long haulers, right? Who actually are working more than 40 hours per month with multiple organizations. So very, very intensive, very, broad ranging, and lots of time being spent in these roles. So I think that the maybe point for discussion here is that these varied role trajectories, I think, require more in-depth examination and exploration to really understand what are the different challenges faced by these patient partners in these different role trajectories, and what are the supports needed and perhaps needed for these different types of roles. And so again, the data, just one of the data slides here to support this, that shows the number of hours spent per month, with that large group spending 10 or less, and then another group spending 11 to 40 hours, and then a smaller group spending over 40 hours. And then the third key message, this is one I describe as kind of the dynamics and tensions within the patient partner community. I don't mean tensions with each other necessarily, kind of interactively, but more philosophically, ethically, and professionally. Again, bringing in these core analytic categories. So, on the one hand, feeling a strong sense of perceived value and influence, and a lot of, really thoughtful kind of comments on how they feel they're contributing and the value they have and the influence they're bringing to their roles. And yet half of them reporting that they're inadequately compensated, and another 2/3 saying we're facing barriers in our roles. And then another group talking about considering quitting their role. So this interesting kind of juxtaposition between, on the one hand, feeling, really enthusiastic, valued, feeling like they're making a difference, but then facing some real challenges in these roles. And I think, again, here, more investigation needed to understand how best to support this role moving forward, given these issues that are coming through in our data. And I think, importantly, to think that some barriers and supports, and we have a lot of them that were identified in our survey, some will be easier, frankly, to address than others. Some of them, I think, will be very, very tough to address. And so again, the data supporting this, right? So we asked a question about perceived impacts in their role, and we had, these are the percentages of agree or strongly agreed with a number of response options they were given, that they agreed or strongly agreed in terms of their influence and being able to affect the thinking of people, paving the way for others, creating new knowledge. So a number of things. And then towards the bottom, some uncertainty about whether they had any influence at all. Couple of other data slides here, and then I'll wrap up. What is the most stressful thing about being a patient partner? This was a really important open-ended question, right? 515 comments, a lot to say here. This in and of itself is probably its own paper, along with potentially this one, which is a question about their thoughts on quitting. And so the question is, have you ever thought about quitting your role? And 40% had given serious thought to quitting their role, and then with a lot of detail about why. So again, tremendously rich data that we have to work with, and we really have only scratched the surface with the paper that I presented today. Another paper that's already been published, led by Laura Tripp on our team, it has a focus on the impact of COVID-19 on patient engagement. So again, one question in the survey asked, how did COVID-19 affect your partnering activities? And we were able to write a paper just on that one question. So just to wrap up, and then I'm going to ask Sandra to make her comments. So for in terms of where we're at, we're now moving into phase 3, which is our interview phase. So this will be a really, I think, unique opportunity to actually follow up with some of our patient partners who completed the survey and indicated that they would be interested in participating in a follow-up interview, to recontact, do some follow-up interviewing to actually explore some of these issues that I've covered today, and many more through an interview study, and beyond that, wrapping up a lot of the different elements of the study, and hopefully producing more that will help to inform our knowledge and practice in this space. So Sandra, I'm your slide advancer, so whenever you're ready.
Okay, so first of all, I'm just going to present on behalf of PAN, and then I'm just going to make a few comments as my own comments. So as you know, from what Julia said, 2 of our PAN members both board members were actively involved from the very beginning. That's Carolyn and Marianne. Unfortunately, they can't come today, but I did ask for quotes from Carolyn. Marianne, unfortunately, is recovering from a surgery. And Elise, our chair. Ironically, I started with Pan after, so, but as soon as I started, this project was, we heard all about in the reporting. So from Carolyn, it says, for Pan, it means so much to have this experience of patient partners documented. Of course, we like to see more publications, but understand that the writing and publication process takes time. And Julie has said that there will be more because this is a rich data set and so much details, like, you know, it's amazing information to have. It's also exciting to anticipate the possibility of a similar study to be conducted sometime in the future to see how this amazing movement has changed and how it has grown. This Canadian Patient Partners study is really a survey of the pioneering era of Canada's patient partner revolution. And we've heard that. The first time I heard that was from Vincent Dumais, who I'm sure you know. Next, she has one more comment, Caroline, on the next page. And it's just understanding the language that patient partners use to describe their activities. It's not the same as the way health professionals and researchers might describe them. So when she says we, is like her and Marianne and Pam people, they needed to get this to make sense for patients and family caregivers. So, and that's where Julia said where they helped out with the survey and that. So our own interests included such topics as why people want to be patient partners, what makes it rewarding work, what skills from other parts of their lives do they bring to the work. That's an important thing. And what barriers and enablers they encounter, and what keeps them continuing to stay involved as patient partners. And Julia's reported a lot on that data. And just a few words from our board chair, Elise. Patient partners have traditionally worked on their own and not necessarily been aware of many others. This survey is a chance to sketch the landscape of a large sample of those of us who do this work and share that back with us. I think that is why so many chose to complete the lengthy survey more than usually do statistically. And yeah, 603 was a lot of people with lots of data. And one more comment from Elise, just a few. If we are to support and promote patient partners, we need to know who they are, where they work, what their obstacles are, and why they do what they do, and so on. Julia and her team's work is a formal acknowledgement of patient partners, their work, and has elevated them to status worthy of study. I think that's it. So if I just like to make a few comments on behalf of myself as a patient partner, and I would be called one of those long haulers. I will be honest with you, I wasn't able to finish the survey. It wasn't because I hadn't heard of it, but when we talked about what COVID did, well, COVID did two things. For some, unfortunately, it made it that if you were working within a hospital, PFAT, you might have not been able to continue to do that. But what it did is open up the door, because meetings and conferences that would normally held in person were on Zoom. And so I can't tell you the amount of rooms or tables that I was at on a Zoom call that I don't think I'd ever be invited to. And at that time also too, I was very, very knee deep or waist deep in putting together our Ontario health team, and just trying to develop myself more in the healthcare patient partner, because I'd come from a research background and now I'm doing both. So the other thing too that we talked about the dynamics about who people are as our patient partners. And we've heard that many times, you know, about white females, retired. And I know within our research groups, we have a hard time getting males to come on board. But we also wonder, like, why we're not reaching people that would fall under, like, like community, like the EDI, like people that come from different cultures, like, for example, the indigenous, the LGBTQ, people living in rural areas. And I really think, like, when you put together a board or a PFACT at your hospital, or when you're working on a working project, sometimes you want to be able to have all those people that you want represented there. But I also don't think it's fair to have one person to say, well, I'm representing the indigenous community, or I'm representing the LGBTQ, or I'm, the ones of people, like majority of people that are affected by social determinants of health. What I believe we need to go to those communities, and we need to be able to find out what they need to be able to participate, or we need to partner with groups that work with those members of those various communities, so we're getting the whole voice. And we also have to look at compensation is a big problem, right? Like, it's trying to, there's a balance, because there's a lot of people that think that, they're just a volunteer. And I'm hoping in this group that people as patient partners and advisors realize that they're bringing the tangible asset, and it's something that's required to help improve our healthcare system, and actually to do research. And so that's an asset that you have, right? And that lived experience, and also too, that was mentioned, is what your background is. People might have background in research, or they might have been working in a hospital environment, or so I think it's important to include that as well. And then just to see if I have a couple more things. Yeah, and the other thing is, like, giving up and wanting to quit. It gets really frustrating, especially when you've been doing it for so long. But I think it's the passion that comes, and we have to remember, why did we get involved in the first place? And I think majority of us got involved in the first place is either we had our own lived experience that was not very good, or with ourselves or with our loved ones, and we want to make sure that doesn't happen to anyone else, right? Or we want to be able to give back and help others as well. And sometimes it gets frustrating, but I think what keeps a lot of people coming back is the people that are in this community. They're so compassionate and passionate about what they do, and they get to work with amazing teams like Julia's and the SPORE units and everything. So continue to plug away, continue to do what you're doing. And I look forward to seeing, a report about this in the future. And also really looking at what Julia's team is working on is the impact of our engagement. So thank you very much.
Great. Thanks, Sandra. I had one more slide, but it was just a wrap up to say, if you're interested in learning more, and to just provide Laura Tripp's email address, and also the website address for our Public and Patient Engagement Collaborative, where we actually have updates about this study as well as our other work. So maybe Laura could put that website address and her own email in the chat, but probably it's pretty easy to find us as well. So I think that's it, Sadia. I guess we're going to stop the recording.